السلام عليكم جميعا. Should we go ahead and start?
توكل على الله. Let's start.
طيب. بسم الله الرحمن الرحيم. والصلاة والسلام على رسول الله. It's my great pleasure to participate in today's Saru rounds. I'd like to thank Dr. Adihim, who is leading and organizing this scientific event for Saro, for the invitation. Our speaker today will be Dr. Mohammed Duhan. Dr. Duhan is a consultant radiation oncologist at King Fahad Medical City, Riyadh. Dr. Duhan completed his residency training at McGill University in Montreal, Canada. This was followed by a fellowship in head and neck and lung SBRT in Toronto. Dr. Duhan will talk to us today about SBRT for head and neck squamous cell carcinoma. So without further ado, Dr. Duhan, please go ahead.
Yeah, thank you for the introduction, and thank you everyone for giving me the chance to present such a topic in Saro rounds. So as you know, we'll be presenting and talking about SBRT for head and neck squamous cell carcinomas. I'll start off with a bit of an introduction, of course, and a background about SBRT, since it's been increasingly used in treatment in treating a variety of cancers. Started off with lung and then so on to different sites of the body. Advantage of a highly conformal dose and a steep dose gradient resulted in a rapidly increased use, of course, of this technique in multiple cancer sites. Has been a surge of use in SBRT in the head and neck cancers over the last decade, I'd say. And what's surprising is that what surprises me, in fact, is that the use of SBRT was first introduced in head and neck in the retreatment settings, and in fact, we would find more data and more literature on retreatment with SBRT. And it does make sense because we really want to treat the least volume we can give. But it did, from that approach, I think the head and neck practice then shifted to using SBRT on de novo head and neck malignancies. I think it's that's the word just described, and of course, when you're treating someone with head and neck malignancy, a shorter treatment time makes it an attractive option, even for treating any kinds of cancers. In fact, especially when these patients are elderly or have multiple comorbidities and they're medically unfit. When we look, I'm going to speak on utilization of SBRT more in particular, not as a curative setting. I'm not trying to, make it more attractive to be as a curative setting for everyone, but more in those who are unfit to receive the conventional treatment. As we know, treatment intensification over now 4 decades or more focused on phase 3 trials for locally advanced head and neck cancers. And they always focused on multimodality treatment, being chemoradiation therapy, altered fractionation, or sometimes surgery followed by chemoradiation. And the survival rates and toxicities, these intensification techniques did improve survival, but also increase the treatment-related toxicity. And it did underrepresent elderly patients. And in fact, there are many, studies in the literature where it did show that the elderly may not benefit from such an aggressive treatment. And they were often underrepresented in these meta-analyses. And in fact, they only constitute 10% of these trial participants. And they are less pronounced when it comes to overall survival benefit. And most likely it comes into age-related comorbidities and inability to adhere to the treatment or tolerate the treatment itself. All right, so what I will be starting with is a case that I have encountered during the beginning of my fellowship. and I'll talk to you how it was dealt with this case, and then later on we'll speak further about the evidence of SBRT as a modality for treating head and neck cancer. So as you can see, this is an 88 female with a large irregular T4 into squamous cell carcinoma of the oral cavity. High grade, had adjacent node that was positive, and in fact had a nodal disease lower down level 4. And you can see how extensive this disease is. For someone with this age, no surgery can be offered, and even systemic therapy was out of the picture. So the patient was treated with SBRT at the cancer center with the following, treatment volume planning protocol, let's say. And we start off with, delineating our GTV as seen on CT sim, MRI sim sometimes, and even try to give IV contrast to further delineate our targets. CTV was not used. PTV was expanded around the GTV with 3 millimeters. And the OIRs that were considered during this SBRT treatments were the following: spinal cord and optic nerves, optic chiasm, and the brain, brainstem, carotids, mandible, brachial plexus, and globes. And as well, what comes into consideration in that case were constrictor muscles and midline structures. The monitoring was done via IMRT or VMAT, and the monitoring was done with daily CBCT with drawdown checking on day 1. The prescription target coverage, usually what they use for their GTVs is 45 to 50 gray to GTV and 40 gray to PTV in 5 fractions, treated biweekly, with aiming to cover the GTV with 99% and aiming to cover the PTV with 95% over the lower isodose line of 40 gray. If this couldn't be achieved, then a 40 gray entirely would be covered by GTV and PTV. And sometimes we may reduce the PTV volume to down to 35 gray or even 30 gray. For all cases, the V 115% was aimed to be kept at 1%. So we're not really doing like the low isodose prescription of the classical SRS prescription or SBRT prescription, but rather try to make the plan more colder than your usual SBRT or usual SRS, let's say, and at the same time keeping it conformal. The machines used there, it was on Linux, Electa Infinity or Versa HD with agility kilometers, and with Hexapod robotic couch, and was planned on Pinnacle 3 treatment planning system. As I told you, Combium CTs were performed daily before treatment. This is the patient that we saw earlier. As you can see, she's been treated with 45 gray to GTV here in red. And she's been on a PTV 3 millimeter expansion of 40 gray. And I'm showing you here the isodose line of the 22 gray. And as you can see, there is a midline ring that was drawn from the midline structure in order to keep and push that 20 gray isodose line away from midline and try to keep it conformal on the GTV PTV. Lower down, it was included, we included the level 1A neck node. However, her level 4 node was ignored as it wasn't significant in size. It wasn't causing any symptoms. All right, so this is the patient MRI scan that was done pre-SBRT. This is an MRI 10 months post-treatment, reading that it has complete metabolic complete resolution of the tumor, a non-viable tumor present, and only treatment-related changes. And this is the patient's image 12 months later after CAR-T. Another case, but I don't have, unfortunately, more pictures regarding that case, and it was treated, this is an 82-year-old gentleman, locally advanced bleeding tongue malignancy, also not fit for any modalities of treatments in regards when it comes to surgery or concurrent chemo, radiation. So the patient was offered this SBRT is a palliative intent. And the tongue mass, in fact, received 45 gray for GTV, and this was expanded to 40 gray BTV margin. I do not have images of, unfortunately, showing you the response of this patient, but I can tell you that he started responding 1 month down the line, and then had complete metabolic, complete tumor response, let's say, after 6 months. 10 months later, he did not develop any evidence of recurrence. However, he did have significant xerostomias, and but believe it or not, he was able still to swallow semi-solid diet, and even was progressing to solid diet. But I do not have any further updates regarding that patient. So the treatment and planning protocol, practical consideration that were done in head and neck SBRT at OCC and other institutions. I'm just going to talk about this briefly prior going to the evidence behind SBRT. So at the OCC, that these are the patients, and how we treat them is, as I described earlier. But you can see there's a variability of different uses in different centers in North America, and some of them do use CTV volumes, but some do not. Some still prescribe to a lower isodose line, but at the end, they all come into agreement of somewhat a similar BED dose to SBRT. This is the dose prescription, and you can see what I was talking about in regards to the dose prescriptions in here, varying results, but when it comes into the BED, we're more or less the same. Some centers may have lower BED, but we don't see higher than 100. Okay, so after this, let's say, so I would consider what was considered crazy approach even by me in 2019. And in fact, 2019, we wouldn't have treated that patient the way I had described. And when we go into the current evidence, I will start off with this nice review of palliative intent treatments. And this is a systemic review where it did reviewed 197 articles of palliation and this patient population, and failed to identify a preferred treatment strategy. 20 retrospective single institution reports were classified as being reasonable quality, and only 4 phase 2 prospective trials were identified with a median patient cohort of 55 patients. So really, it's a tricky, patient population to deal with, and no real strategy has been developed, and no randomized phase 3 studies were actually identified in that review. That review is a bit old, in 2018, but in fact, till this date, we don't have something clear in terms of choosing the right approach for these patients. So older me, when I saw patients like that, I would consider a quad-shot palliative approach. And in that classic quad-shot study, what they did is they had 30 eligible patients on a phase 2 arm prospective study, a single arm prospective study, and they had 29 stage 4, and their performance status was common at the 2 and 3. They had at least 1 treatment, and 16 patients completed all 3 cycles of the quad shot. The 53% had an objective response, and 2 of them had complete and 14 had partial, and further even had stable disease, in fact. The median overall survival was poor as usual. In this population, it was 5.7 months with a really poor median PFS. However, the treatment was very well tolerated and improved quality of life in 44 patients. Bear in mind, the treatment duration of these patients, if I am to get them into all 3 cycles, would take them up to 3 months, and a total of 12 fractions. And every time I bring them, I'll need to treat them BID for fractions. So it is, you know, a logistical difficulty to both the patient and also the radiation oncologist. So further down the line, some centers try to emulate the quad shot, where they used more conformal techniques rather than, you know, the classical techniques that were used in the quad shot. And in fact, this retrospective review reported their institutional experience for 75 patients completed at least one cycle of palliative RT for primary or metastatic head and neck cancer. The median patient age was 76. Not the majority were squamous cells, and the 65% of the patients, in fact, had some reported response, and the grade 3 toxicity was, in fact, low. The independent, of course, predictors were the greater number of cycles, the better. So meaning that, you know, you have to get them through all 3 cycles of that quad shot treatment. Their grade 3 toxicities, in fact, was a bit slightly higher than the toxicities reported in the RTOG trial. Further down the line, there is another Japanese study that even just recently published their quad shot results of their center, and they included 105 head and neck patients. And then here, they did complete, the patient who completed the 3 cycles were 73%, and sometimes concurrent systemic therapy was in the picture, but in really a big minority. And they had a tumor response of, very impressive tumor response in 88 patients. Symptom relief was in 71%, and the median OS is 6.8. The only issue is that in this trial, in this review, in fact, retrospective review, they don't really view the details of the toxicities in detail. They only name the grade of toxicities, but not really telling what it is. And it is a retrospective review. However, it does give us a suggestion that this approach is actually a reasonable approach in this population, but still a logistical, you know, difficulty. Survival estimates with the usual palliative radiotherapy approach in North American, to be more specific, in Canadian centers. As you can see, there are different centers that use different palliative approaches, 25 and 5. In Quebec and Odette, they use their SBRT. At Princess Margaret, they use the 0721, and as well at Hamilton. And when we look into the 1-year OS, we look at the Odette, and it seems to be suggested that it's the highest. Again, it's all retrospective, so we need to interpret this with caution. However, this gives you a suggestion: the higher the dose, the better. But when you raise your dose, it does come at a cost, in fact. But you have to, you know, find that balance. And in fact, when it comes into tumor response, the highest was associated with SBRT approach. Palliative radiation therapy, furthermore, about it, and this is another approach that I use to use as well when facing a head and neck malignancy, especially if it's a squam and nothing else works. So, and we try to push more than the 20 gray. And this, we go, you know, slightly higher with 25 gray and 5, finishing the patients in 1 week. It was a prospective study, phase 2, and used quality of assessment tools. And in fact, showed, you know, tested 32 patients, and the questionnaire completion was at 86. The 88 patients did receive the planned dose, and they had a good, well, a similar median OS, 6.5 months. No grade 4 or 5 toxicities. Grade 3 toxicities were observed in patients, and 17 reported, in fact, no toxicity at all. However, their symptom response wasn't really, you know, properly assessed despite using a quality of life questionnaire. They ended up by, you know, concluding that the quality of life either remained equal or slight or improved. But how did it improve in terms of the degrees? It was a complete response or a partial response. It wasn't really clear to me. And as well, from that approach, 85% of those patients questioned would have chosen to receive this RT regimen. So it's a really short course, 1 week, and it helps them, alleviate their symptoms. So we're done now from, the palliative approach in head and neck malignancies using our usual conventional doses. We'll start off with the SBRT, and I think the best way to start it off is starting off with a systemic review and a meta-analysis that was done and published in 2020. In fact, viewed several studies. Over 157 patients were studied, and the local control rates were reported as at 1 year up to 90%, 2 years at 81, 3 years at 73, and overall survival starting at 75 and 1 year, with late grade 3 toxicity rates of ranging from with an average, of course, of 3.3. But I would caution about this review that it had the quality that was reviewed was they reviewed mostly retrospective data and few prospective data, and I will show you now. So no randomized data summarizing SBRT for primary head and neck cancer, and small retrospective series published, with, of course, the biases that it comes with, but a total of 157 patients were tested in that analysis. And in those trials that they have tested, in fact, just to let you know, the first 2, they were prospective in fashion, but in fact tested laryngeal SBRT, and both those 2 were really toxic. The first one, really, the Korea study closed due to grade 4 toxicity, and the second one as well showed that there was a highly associated risk of laryngeal edema when you use these SBRT approaches. And in the parotid retrospective review, there was in fact a grade 5 toxicity. However, what we take from this is that in some incidents where the doses were ranging from up to 40 gray to 45 gray, were still safe, and the numbers that I presented in terms of grade 3 toxicity were less if we exclude those 2 first trials. Summary of data for the de novo head and neck SBRT. Late grade 3 to 4 toxicities is 3.3, and the 0.1% was from that study that I talked to you about. And it shows you that curve of overall survival. However, it's a collective and it's a mixed bag, and it's not really a full representation of squamous cell carcinoma in particular, but rather a mixed bag of head and neck malignancies. Another review that was done for SBRT non-metastatic head and neck cancer, and just to show you the table and what it showed in terms of different retrospective analyses that were done, and in fact the showing good local control rates with a higher dose per fraction approach, and in fact that approach has been done since 2009. The ongoing trials where they're doing it in a prospective fashion, few ongoing and have started, and from all these 3 trials, only 1 included the elderly group, which is the SHINE, and in fact there is another trial growing I'll talk to you about at the end of this talk. So only 2 trials are testing it on the elderly. The remaining others were testing it on many different group populations, even in the post-op setting. This is also from the review showing that the local regional recurrence, in fact, in SBRT, when you treat an untreated head and neck malignancies, they did the best when it comes into local regional recurrence. Furthermore, another systemic review, review was done. In fact, just recently, earlier this year, and what was added into it is another approach of another retrospective review of 106 patients, mainly skin. It was also on a dead cancer center, and did give a good local control rate suggestion. But this is also a mixed bag of skin cancers, not head and neck squamous. I'll talk on a few reviews that were done in the past. This is one that was done and tested the Odette Cancer Center. And in fact, they tested biopsy-proven head and neck malignancies or metastatic disease of non-head and neck primaries. Patients deemed unsuitable for the radical treatments were tested or were looked at retrospectively. And from the results of that paper, they had 67 who were never irradiated. 2/3 of them were squam, and majority, 1/3 of them were ranging between the T3, T4. The most common dose was 40 gray and 5 fractions. And you can see the mean GTV being at 54 cc's. When it comes into toxicities, in fact, they did have grade 4 ulceration, but it was really only one case of that has occurred. And when it came into late toxicities, they had one grade 4 necrosis and one grade 4 ulceration. And when it comes into hospitalization, the rate was quite low, and it was 8.55. And they used the approach of Odette Cancer Center SBRT approach that I have explained to you earlier. Another study that also tested later on retrospectively the head and neck squam in particular, and they have the highest number published so far when it comes into inoperable squamous cell malignancies. The median age was around 80 years, and all patients completed their SBRT treatment. However, 34 patients received concurrent systemic therapy or sequential. No real details of how did they receive this and when, in fact, but the systemic therapy was introduced here. Their median age was around 80. They had the OS was quite impressive, in fact, at 73 and 64, and only 2 patients experienced a grade 3 toxicity. The median time to local failure was 28 months, with 21 in field and 4 marginal failures. But what's surprising about this paper is they never viewed any sorts of, Kaplan-Meier curves or survival curves, and that makes me question, the validity of all the results. However, it does suggest to us that it is a fairly safe approach, and the approach they did when it comes into prescribing SBRT treatment, in fact, is somewhat similar to that Cancer Center, and it was in a bi-weekly fashion. And also, it wasn't really truthfully squamous cell carcinoma. In fact, they had a mixed bag of melanomas and others. As I told you, there was a mix of systemic therapy. So it wouldn't be a fair comparison to the other review studies that I've viewed to, where only one modality was used in this population. And their treatment in that paper that I presented is all the patients were treated with SBRT, consisting from 35 to 40. What they differed when it comes into the Sunnybrook approach is that sometimes they did include the CTV volume, and it was prescribed at 30 gray. All right, so that's really the descriptive studies and retrospective studies that are present to date. And in fact, none of them are of a high quality, prospective fashion, unfortunately. However, this is the best, data we have to prove that, SBRT works. What's coming soon is, this is another review and a project I was working on during my fellowship in Sunnybrook. And in fact, we reviewed 77 tumors in 74 patients with purely mucosal, unirradiated squamous cell carcinoma. The median age was 81. Majority were at the ECOG performance status or higher. Most patients came in with a locally advanced disease, 64%, and the mean GTV size was at 62 cc. SBRT doses ranged from 35 to 50. 95% of the patients did receive 40 gray or more, and 81% of them completed the treatment within 14 days, and 100% of them then completed the treatment after 3 weeks. And the median overall survival that was recorded in this retrospective paper, or let's say study, was around 8 months. And when it came into local control or local failure, at 1 year, it was around the 18, let's say 19%. And it persisted to be quite good even at 24 months. The local control was around 79 to 80%. Further down testing this population, the symptomatic relief was reported and similar to the previous publications, up to 84%. The 1 year local control was 81. The local, or let's say regional control, was at 16. Distant mets was at 12%. 84 did report somewhat symptom relief, with 5% of them confirming complete symptom resolution. And then when we looked at those who had complete response as per RECIST criteria, only 2% in fact had local recurrence. Only 2 patients in fact had local recurrence out of the 21. The most predominant symptom was pain and mass effects, followed by dysphagia. And the most common tumor site was oral cavity cancer. And the hospitalization rate was and still remained to be similar to what was published previously at 8%. However, toxicity did differ in this review, and the acute grade 3 toxicities, in fact, was somewhat similar to what was presented in the past. However, it pushed down to 36% of patients, and mostly due to mucositis, 30%. The 8% patient required hospitalization, as I told you, and the late grade 3 toxicity was observed, in fact, in 9.5% of patients. And this is an analysis and more detailed analysis of these grade 3 toxicities. And in fact, 57 of those patients who had late grade 3 toxicities had residual or recurrent disease. The remaining others, it was purely a real grade 3 toxicity. And the first toxicity, as you can see in here, it was 2 where they had purely a grade 3 ORN, required medical management, and 1 required surgical management, in fact, and debridement. The grade 3 dysphagia had a residual disease. The grade 3 ORN had an oropharyngeal ulcer. However, there's a grade 5 dysphagia where there was a progressive disease, and the labeling of this grade 5 is somewhat debatable. I'm not trying to downplay the side effects of this analysis. However, that patient who received had a huge base of tongue tumor, and in fact was offered PEG tube placement and declined it during therapy. However, he did die during his radiation treatment, and so on. This toxicity should be labeled as grade 5. Further analyzing these results, and in fact, doing a multivariable logistic regression analysis for the late toxicities, especially the grade 3, and we found that higher PTV values were more likely to have higher probability of developing grade 3 toxicity. Furthermore, fishing for results, we found out a cutoff line of size when doing an ROC analysis, and we found that when the larger your PTV size, the more likely you're going to have more grade 3 toxicities. And in fact, we found a cutoff of 159 cc of PTV volume. But then again, I don't think this can be, taken into consideration and being decisive in your, on your cutoff, but does give you a suggestion of when to, cool down your SBRT approach. This is just a table summarizing the previously published research on SBRT on mucosal head and neck squamous cell carcinoma. And unfortunately, everything is retrospective, but showing this results. And when we compare these results to the previous retrospective results, they were somewhat similar, apart from the higher grade 3 toxicities, I'd say, and the grade 5 toxicity being reported. So when are we having a final answer? That this approach can be doable and can be considered the standard of care. Unfortunately, we'll have to have prospective evidence, and the prospective evidence that is testing this is firstly a phase 2 study of SBRT for squamous cell carcinoma of the head and neck, a single arm study where it accrued patients who are unfit for the usual treatment, and then they will start following them up in a prospective fashion. The planned sample size is 38, and I believe they accrued last year, and they will probably be hearing from them in 3.5 years, or maybe 2 years down the line from today. The other study, and this is even a more inclusive study, where they did a phase 3. They're doing a phase 3 randomized RCT, and this will be the first in this patient's population. And they will be comparing this approach with the standard of care, let's say palliative approach, being either 24/3 or 25/5. And they will be using the overall survival as a primary endpoint. However, all the other endpoints that we talked about will be further analyzed. And this will, I think, give us the final say or final answer in terms of standardization of this approach to make it a gold standard. So to conclude, I think from what we have in regards to literature, I think we've established that this approach is better than our usual standard of care approach in palliative setting. And in fact, when it comes into symptom resolution and symptom improvement, this modality does seem to be one of the best modality used. One needs caution in using this modality, of course, and you have to be careful in delineating your volumes and in selecting your proper patients. But I do think and believe that these patients are probably there, and even here in Saudi Arabia, will be having these elderly patients and aging patients that require this approach. What I would caution about when approaching this is, when you approach a laryngeal cancer or a base of tongue or midline tumor, we need to treat these areas as a no-fly zone of the head and neck, and need to reduce the doses down below 35 gray, or even lower at some points if the volume is really high. But when it comes, into pushing to use this approach, my opinion will be very biased, and I will probably say, use SBRT palliation and try to use SBRT palliation, and if you can't, then come down to your 25/5 or your quad shot or any other approach that is similar to this, quad shot approach, where you give the patient some breaks. But bear in mind that this is a longer treatment duration, and bear in mind that this patient population do not survive more than a year. So the less treatment you give them, the better, and the better symptom resolution, the quicker the symptom resolution you give them is also the better. Thank you very much for listening to me, and open for any questions and discussions.
Thank you so much, Mohammed. Very informative and thorough presentation. Pretty much the use of SBRT in head and neck cancer in clinical practice nowadays will be on patients who are not fit to get the usual full course of radiation, elderly patients, or for palliation. Still, for de novo and for curative cases in fit patients, I think it's only on clinical trials. I have many questions. I'll just ask one question and give the floor maybe for our colleagues to ask. So, what's your take for not in a palliative setting? Like, let's say if you have a patient with nasopharyngeal carcinoma, treated initially with definitive chemoradiation, he's young, healthy, and then he developed a recurrent disease purely in the nasopharynx, no neck, nose, nothing, just very localized disease. In these situations, is there any role to re-irradiate with SBRT instead of usual normal or hyperfractionation radiation therapy?
I think it depends on your recurrent disease and how big it is. But, in nasopharynx, if you have a reasonably sized, recurrence, and you caught it early, in fact, it's one of the first diseases that were treated with retreatment SBRT at the neck. When you have, that's a safe, AQD2 calculations from the prior treatment. And what's ideal about the nasopharynx, sometimes the recurrent nasopharynx, not all the time, but sometimes you could catch it early and have a really small volume and you could treat it. But what makes me go against this approach, in fact, in nasopharynx in particular, is that there is a just recently published Chinese trial where they published the retreatment of nasopharynx by hyperfractionation. And in fact, they did show quite safe and good results, and it was tested in a randomized fashion and it was tested in a prospective fashion. But again, this is not what you can face in real life. Sometimes you may have a smaller tumor where you could manage it with SBRT, and I think it is practically if it's practically doable in terms of safety, I think you can approach this with SBRT. But the dose, I wouldn't recommend the full doses that I've been talking about, ranging from the 40 to 50 gray. I would, treat it with I would say ranging from 30 to 35, depending on where the location is.
Okay, thank you. Any questions from the audience?
We have something in the chat from Dr. Dennis. How many cases of radionecrosis have you seen in your practice for head and neck SBRT? Do you have any recommendation about
hyperbaric oxygen?
And also do you use PET for contouring and assessing treatment outcomes? So for me, I would say, during the SBRT approach, I've seen one patient who had ORM, but it was asymptomatic from SBRT, did not require any hyperbaric oxygen therapy. However, when you have an SBRT necrosis, I think you should treat it as any radiation necrosis related to head and neck treatment, and for sure, hyperbaric oxygen therapy can be, tried, and it may help. When it comes into delineating, in fact, PET is a useful tool, especially if you can't MRI that patient. And it will be a useful tool in delineating your GTV. However, it may be a bit challenging in some cases, depending on where the location of the tumor is. So if you have to treat with SBRT, I'd recommend that you'd use an MRI. Unless you can't, then I would rely on other modalities, the PET scan, and also you'll need to rely also on your clinical exam, your scope exam, your oral cavity exam. All of these things need to be taken into consideration in delineating with SBRT, because you really have to be now in your margins. It's not the usual, CTD expansions that we do, the 5+5s. So you have to be very careful, and at the same time, you have the smaller the volume, the safer for you to deliver, and the higher dose and the higher room you have for higher dose approach, I'd say.
Great. Okay, so we have another questions. So do you think Radiomix would personalize the dose rather than volume-based decision?
Well, I think it can, yes, but again, volume is really important. It's not because of the size itself, but rather what normal tissue is adjacent to it. So let's say you have a parotid mass and it's quite peripheral and away from any critical structures, let's say. All you have to deal with is your skin and maybe the mandible if you're close by as well. And of course, the salivary gland will be probably gone when it comes into function. But when you have another tumor, laryngeal tumor, let's say, or supraglottic tumor, smaller in size, it wouldn't be as safe to deliver SBRT.
Okay. So another question we have: do you think adopting SRS acceptance would be safe?
So adopting SRS acceptance would be safe. Not sure I understand the questions. It's like adopting the SBRT in head and neck malignancy, is that it?
Yeah, I'm not sure what is SRS acceptance, if they mean maybe SBRT, not SRS.
Well, I mean, it would be safe if you can properly do it. If you can properly delineate your volume, if you can treat it with the best available evidence, let's say. It's not great, but this is the best available evidence we have. And in fact, it is what we use, so known as, from what was demonstrated, it was fairly safe. However, you need to be cautious when you're near critical structures.
Okay, let me just, if you can elaborate more on the safety for SBRT use. So is there like any situation will make you decide on a different dose regimen, for example, volume or size of the tumor, or a tumor, for example, encasing a carotid artery or extending to the skin and requiring bolus? Is any of these factors makes you just like shy away from doing the SBRT and go back to the normal IMRT or usual palliative, pure palliation?
Well, yeah. So it depends on the situation of where the tumor is. Like if we go back to that case that I've shown you here, let me go back and just to be more inclusive in there. So we have a case like this, really, and you can see the skin infiltration here. In fact, makes you deter about really treating this patient with a big full dose. But at the same time, we need to know what is causing this fact, and what's causing it is a growing tumor. So if we stop the growth, we'll probably cure in that area. Sure, you have normal tissue around, and you might end up with having a bad toxicity. But when we viewed these toxicities, they're in retrospective fashion, of course. It hasn't been viewed prospectively. All of them were related where there was a recurrent tumor around or something growing. But if you really give your full dose and the patient tolerates it and have complete response, makes me favor to do that approach. And this particular patient, let's say, and in here you don't have any. We do have a lot of organs at risk to worry about. However, it is quite far away from that midline typical structure of your head and neck cancer. So when I have these patients, I think I wouldn't shy away from a high dose. I'll give them the highest that I can, especially that the ORN I'm worried about is already occurring in that patient symptomatically from her tumor. So the teeth is gone, the mandible is gone and destructed, and really it's a quite bad disease. So in this situation, I would, be more eager to give a higher dose. But let's say a situation where I had a patient with a base of tongue cancer, or let's say supraglottic cancer, I wouldn't approach it the same way. I wouldn't offer 40 gray. I wouldn't be offering 50, the equivalent of 1511 that was done in the prospective trial, the Korean prospective trial. So my safest dose would be, I'd say, from 30 to 35 gray if I'm pushing it. But I wouldn't go higher than that in the midline region, especially around the glottic, supraglottic region. That's the situation. If a situation occurs, let's say, around the carotid, encasing the carotid, the tumor is encasing the carotid, if you think about it. And when you irradiate such tumors, they are associated with blowout, fortunately, but there are many, reviews of the blowout, carotid blowouts. And in fact, there was a review in particular in the retreatment setting. In fact, viewed that whenever the whenever the EQD2 dose is at 100, not exceeding the 100, or not exceeding the 40 gray in 5 fractions, the association of carotid blowout is less than 5%. So when I have a carotid blowout, I would probably aim to treat it not more than 40 to be safe. And I'll try to avoid the hot spot from the carotid, but I wouldn't shy away from, pushing it. If, of course, it is adjacent to the areas of optics, then that's a different story. If it's adjacent to the brain, it's a different story. I have to calm down the areas of concerns in the base of skull. And I have to meet the known constraints that we use from SNS treatments and even different other modalities. But bear in mind, the way we're treating in here is a different approach when it comes into SBRT. We're not treating daily. We're giving only bi-weekly. So we are allowing that potential, recovery of normal cells. And at the same time, we try to give hyperfractionated dose to the repopulating cancer cells. I hope that answered the question. But
very clear. And in terms of like radiobiology, like when you're choosing the dose, is there a number for the BED dose that you're aiming to when you're prescribing the SBRT, choosing the dose in how many fractionation or no?
I would say the aim is to the closer it is to the 70 gray BED of 10, the better.
Okay.
So meaning it's 40 gray or 38 gray. 40 is around 72 BED of 10 EQD2. So that would be the radiobiological aim, only because this was tested. This is the only evidence we have that was tested, and only in a retrospective fashion. And this is what is being tested in a prospective fashion and in a randomized fashion as we speak.
Excellent. Okay, we have one more question. Is there any role for SBRT use as a boost?
Not in the de novo setting, I'd say, but we could, you could consider SBRT boost in the situation where there was a study that I showed you where they did 40 gray to the primary disease, and they did cover everything else with 25 to 30 gray as dose line, like the draining lymphatics and involved nodal regions. But no, SBRT as a boost is not being used. But it is something that can be considered in some situations. If you use a CTV volume in these cases, which is quite rare, but if it is used, that's your boost, more or less.
Okay, so back to the SRS question. So the question actually point to regarding when you're prescribing, choose the 50 or 80% coverage to spare as much of normal tissue as possible.
So yes, of course, we try to push. We try to meet the R50 as per the guidelines of SBRT for body SBRT in general. And as you can see, similar to this case, if you see the 20 gray isodose line, which is almost even more than half of the isodose line, we try our best to push it from midline. We try our best to push it from any, mucosal, normal mucosal structures. And sometimes even we try to push an entire high dose or D point max from an organ. But yes, I'd say we are very careful in choosing these things. We try to, and if we see that it's unsafe, especially like, in this situation, let's say, if I saw that there was a 35 gray isodose line covering this entire area, I wouldn't accept this treatment to be done on this patient.
Excellent. Any other comments, questions from anyone? Okay, because we are approaching almost 8 o'clock. Just one more last question. Is there a size cutoff for you to use the SBRT? Any size or volume or
Yeah, so the only size we have right now, I think is, nobody really analyzed the size apart from this paper that is yet to be published. And the cutoff criteria that we've reached to decrease the association of grade 3 toxicities is, 159 cc. But I would caution about this still because this is retrospective. But you need to bear in mind, whenever you reach that volume, you need to be extremely careful. I think for me in my practice, if I reach that volume, I wouldn't go higher than 40. I'll probably treat 40 GTV and maybe give GTV and maybe give a lower isodose margin of BTV to 35. And sometimes even I would accept a 32 gray coverage rather than 35, depending on where I am, especially if I reach that size criteria here.
Perfect. Thank you very much. Okay, so if no further questions or comments, we can conclude. Thank you so much, Mohammed. Very informative presentation and discussion as well. And thank you everyone for attending and listening to us today.